Hi, my name is Paul Wu. I'm the interventional pain physician from Holy Cross Health. Today's my topic is spinal cord stimulation application in Parkinson's disease for pain and motor symptoms. My disclosure is follow. And in terms of chronic pain in Parkinson's disease, the prevalence is pretty high, is much higher than the general population. Up to 95.4% of people with Parkinson's complain of pain. Pain in Parkinson's disease usually correlate with factors such as rigidity and daily living activities. Chronic pain is the most significant predictor of quality of life in Parkinson's disease patients. The pain is often unrecognized and usually results in undertreatment. Different types of chronic pain in PD include musculoskeletal, neuropathic, dystonic, as well as other type of pain such as akathisia, restless leg syndrome, as well as gastrointestinal, etc. We're going to focus particularly on musculoskeletal and neuropathic pain today. In terms of musculoskeletal pain in PD patient, up to 45 to 90% of patients complain of pain. In terms of musculoskeletal etiology, usually is due to postural changes as well as muscular rigidity. Other type of musculoskeletal pain complaint including frozen shoulder, low back pain, arthritis, as well as osteoporosis, in which low back pain is the most common. Up to 71% of patients complain of low back pain in PD patients. And the etiology of a low back pain, most of them are arthritis, scoliosis, as well as spondylolisthesis. This can result, just like in general population, in lumbar stenosis, which subsequently might require surgical treatment and as a cause of chronic post-surgical back pain. In terms of peripheral neuropathic pain, there's radiculopathy, again, due to postural changes or bony changes, arthritis, as well as stenosis. And there's also the traditional peripheral neuropathy, which occurs in about 20 to 31% of PD patients. That can be due to malabsorption of vitamin B12, secondary to a levodopa-induced malabsorption, as well as homocysteine, as well as methylmalonic acid deficiency. Additionally, peripheral neuropathy in PD patient can also due to abnormal alpha-synuclein deposit in the nerve fibers. The other type of neuropathy pain is a primary or central neuropathic pain. This type of central pain could be related to Parkinson's disease pathology. Usually this is described as intractable, stabbing, burning, or scalding, and occurring 4 to 10% of Parkinson's disease patients. Central pain may be due to dysfunction of pain pathways in the central nervous system. In general, when we talk about pain pathway in central nervous systems, there are three major ones. They are sensory, discriminative, or lateral pain pathway, emotion motivation, or medial pain pathway, as well as descending anti-nociceptive system. In Parkinson's disease, Lewy body can accumulate in structure in medial pain pathway in the area of periaqueductal gray, or PAG, as well as pons at the parabrachial nucleus, which is responsible for arousal, as well as locus ceruleus, which is responsible for physiological response to threat and panic. PAG involves in ascending pain and temperature fibers of spinal thalamic tract, autonomic function, as well as a motivated behavior response to threats. Lewy bodies also occurs in caudal interlaminar nucleus, as well as nucleus centralis medius in thalamus. Both nuclei have connection to basal ganglia and medial pain pathway. Additionally, dopamine as a neurotransmitter is also involved in emotion, motivational aspect of the pain processing. Therefore, Lewy body in medial pain pathway may result in increasing in pain rumination in Parkinson's disease patient. In central neuropathic pain, the lateral pain pathway is relatively preserved in terms of lesion by Lewy body in Parkinson's disease. However, nigrostriatal system denervation, which occurs in Parkinson, can cause neuronal hyperactivity in subthalamic nucleus, basal ganglia nucleus, basically can cause strong inhibition of lateral thalamic region. This results in two things. One is this inhibition of medial spinal thalamic cortical pathway or medial pain pathway to the anterior cingulate cortex, which, as we mentioned before, can cause central pain. Additionally, it can also, the hyperactivity of those regions mentioned can also cause reduced lateral pain pathway sensory discriminative function, such as, and that can cause a poor pain localization. So this is a slide of spinal cord stimulation anatomy. Basically, we're just showing the medial and lateral pathway. On the left side right here, the blue area, this is a lateral pathway, and on the right, this is a medial pathway. I'm not going to go through every single detail, but essentially on the lateral pathway, the destination is S1 and S2 cortex through the lateral thalamus nucleus, and on the medial pathway, it goes through medial thalamus nuclei, and the destination is the anterior cingulate, as was a rostral insula. And again, the affective emotional pathway is medial pain pathway, and the lateral pathways for sensory discriminative pain processing. This is just a summary of a different type of chronic pain in Parkinson's disease. Again, we mentioned musculoskeletal, peripheral, and central neuropathic pain. We're going to specifically focus on, in terms of treatment, specifically focus on dorsal column stimulation as its evidence and the theory in application in Parkinson's disease. In terms of spinal cord stimulation, this has been around in human history for a long time. First, it has been reported in the Egyptian papyrus back in 31 BC, where it shows using electric now catfish for pain control. As in the first century, Roman had used torpedo fish for headache and gout. In the 1800s, well-known people, scientists such as Franklin, Faraday, Galvani, they all use electricity medically. In the 1800s and 1900s, there actually were electrical stimulation device marketed for pain treatment. This is more along of superficial stimulation. In 1967, Dr. Sweet, as was Dr. Wall, they had collaborated and used electrical stimulation for peripheral nerve and actually published in Science. In 1967, a neurosurgeon by the name of Norman Sheely was the first one to use a spinal cord stimulation system, which is an intradural extramedullary electrode in a cancer patient, and his pain was relieved, and this was done at Cass Wilson Reserve University. In 1968, commercial spinal cord stimulation system was available using low frequency stimulation. Today, they are both a wireless radio frequency based spinal cord stimulation system as well as an implanted system available using multiple stimulation waveforms. Waveforms is pretty much a basis of spinal cord stimulation as its efficacy, and in general, there's two broad categories of spinal cord stimulation waveforms. They are basically paresthesia as well as paresthesia-free stimulation. Paresthesia stimulation is using low frequency, 40 to 60 hertz, with a pulse width of 150 to 500 microseconds. The amplitude can be changed to adjust the strength. In terms of paresthesia-free spinal cord stimulation system, there are a couple of types, but most importantly, burst, which is what we're going to focus on. is basically 40 hertz of 5 spikes groups, which you term burst. And within each spikes, there's it's run at 500 hertz with a pulse width of 1,000 microseconds. Between the burst spike, there's 1,000 microsecond pulse width as well. Then there's a high frequency spinal cord stimulation or high rate spinal cord stimulation. They range from 1 kilohertz to 10 kilohertz. Other type of stimulation are dorsal root ganglion, as well as most recently in developing closed loop stimulation. Again, I mentioned before, there's 3 pain processing pathway, lateral medial pain pathway, as well as descending pain inhibitory pathway or anti-nociceptive system. In terms of anti-nociceptive system, which I didn't mention before, the structure involved including dorsal anterior cingulate cortex, which is going down to the periaqueductal gray, and then that in turn relate to sensory somatosensory periphery nervous system through the spinal cord itself. In general, burst and tonic spinal cord stimulations, which is what we're going to talk about today, modulate both ascending lateral pathway as well as descending pain inhibitory pathway or DAS. This is just some pictures of the different type of waveform. On the top, you can see that this is a low frequency stimulation. You can see the pulse width, and you can see the frequency. This is a burst. You can see this is a spike, and you can in between the spike there's a pulse, and that's a burst. This is high frequency. You can see this is 10K or 10,000 hertz frequency. You can see if you amplify this area, you can see this is much more is similar to a square wave, except this is much higher frequency. This latter 2 type are paresthesia free, and this is with the paresthesia, meaning that you can one can feel tingling sensation in the extremities or arms or legs, depending where they put the stimulation system. This is basically depicting the location of spinal cord stimulation system. You can do it at dorsal column or in the epidural space, or DRG, which is the stimulations directly at the dorsal root ganglion. The theory of spinal cord stimulation is not definitive. In general, paresthesia spinal cord stimulation has the largest evidence, since that has been used for the longest time. The basic initial theory is what we call gait control theory of pain. This is developed by Dr. Malzak and Dr. Ward, the 2 neuroscientists who came up with this theory. And it's basically saying that the tonic stimulation of alpha beta fibers and inhibitory interneuron lead to inhibition of pathological wide dynamic neuron firing and modulating the alpha delta as well as C fiber input. So basically, the stimulation and paresthesia provided by a tonic stimulation basically overshadow or overtake the inputs and block the inputs from the pathological firing signals. However, there's evidence for multiple other potential mechanisms. Antidromic alpha fiber activation through the stimulation can retroactively or retrograde activation of inhibitory interneuron, which exert presynaptic control over the injured projecting neuron firing from a peripheral source. In rat model, spinal cord stimulation electrical field also cause increase in GABA and decrease in glutamate, which are 2 major neurotransmitter in dorsal home via presynaptic GABA inhibition. And this has been shown to improve allodynia in rats. It's not unclear which of these 2 mechanisms is greater, either antidromic activation via alpha beta afferent or direct localized electric field causing the inhibition action of an interneuron. Additionally, there's also possible attenuation of glial cell or inflammation or gliosis. Glial cell can produce a glial mediated release, which can cause neuroinflammation, and this can be due to peripheral projection neuron or peripheral nerve injury, and this can be also happen at the level of DRG. Additionally, orthodromic dorsal column activation also facilitate the DAS or anti-nociceptive system by triggering the supraspinal inhibitory serotonergic descending system, resulting in increasing in dorsal horn serotonin. This is just to give a better picture in terms of what we just said. It's a lot, but the key thing is that if you have, you can see that with a spinal cord stimulation, orthodromic activation to the PAG area, which is supraspinal center, can cause actually a modulation of a descending pathway, as well as the areas of the medulla, which in turn can cause changes, signals to the dorsal horn. Basically what it does is results in the increasing the right neurotransmitter and decrease the transmitter that tend to be increased during the disease state. So the blue here, all this neurotransmitter, decrease glutamate, increase serotonin, increase GABA, increase acetylcholine, counter the red neurotransmitter, which actually is a result of the injury from the peripheral nerve, which in turn can cause abnormal firing from the dorsal horn neurons. This slide basically is a summarization of a spinal cord stimulation mechanism. The two things that I want to pay attention to is this two statement here. In the development of chronic pain, neurocircuitry undergoes rewiring, wherein abnormal enhancement of excitatory pathway and loss of inhibition facilitate nociceptive transmission to subthreshold stimuli. And basically what spinal cord stimulation does is it changes the balance of nociceptive and anti-nociceptive input through the activation of local, segmental, and descending supraspinal mechanism to impart, restore balance to this network. So basically while development of in developing of chronic pain. This slide basically is just a summarization of all the influence of spinal cord stimulation on neurotransmitter concentration. I'm not going to go through all of them, but you can see GABA, serotonin, substance P, noradrenaline, acetylcholine, as well as glutamate and aspartate has also all changed to more toward normal balance. The burst spinal cord stimulation is a relatively new discovery within the past 2 decades. It's a stack pulse paradigm for charge delivery. The exact mechanism of burst spinal cord stimulation is unclear. There's endogenous neural burst firing, which is ubiquitous neural axis. It can cause a single action potential, or if it's increasing amplitude, it can be 2 or more action potential. The burst stimulation modulate a neuron in medial dorsal thalamic nuclei, which actually project to anterior cingulate cortex as well as dorsal horn. Both burst as well as paresthesia spinal cord stimulation attenuate wide dynamic range neuron activity to noxious stimuli. However, administration of GABA receptor antagonists abolish such attenuation in paresthesia spinal cord stimulation, but not in burst. PET study has shown that the burst spinal cord stimulation modulate dorsal anterior as well as posterior singular cortex, which is more in medial pain pathway, more so than the tonic stimulation. Posterior singular cortex is important in pain rumination, and is a hub for default mode network, which is a part of opioidergic, serotonergic, as well as dopaminergic, descending active antinociceptive system through the perigeneal anterior singular cortex. This results in activation of PCC, cause activation of default mode network, which induce antinociception. The burst spinal cord stimulation also modulates supraspinal affective emotional pathway, as well as a lateral pathway into a descending pathway. These are just a summary in terms of what each type of spinal cord stimulation can do in terms of burst versus paresthesia, as well as other type of stimulation. In general, the indication for spinal cord stimulation is as follows. FDA is approved for spinal cord stimulation treatment for pain in trunk and extremities. Based on the most recent neuromodulation appropriateness consensus committee recommendation, and based on the existing evidence, spinal cord stimulation has a grade A evidence for with a level 1 strength for failed back surgery syndrome, and a grade B recommendation for radiculopathy, for upper extremity neuropathic pain, has a grade A recommendation, as well as a CRPS type 1 and type 2 both have strong evidence for usage of a spinal cord stimulation for treatment. In terms of spinal cord stimulation treatment, PD, any kind of indication for general population also apply to PD. However, it's unknown if what's the effect of motor system symptoms when spinal cord stimulation is used for treatment of pain. Lead placement for in PD population generally is located at C2 to 3 level or mid-thoracic levels. However, all available studies are small case series or case study. The one of the earliest study is by Fenelon. Basically, is one patient, 74-year-old, with a 5-year history of Parkinson, no history of DBS used for failed back surgery, placing mid-thoracic level with a tonic stimulation, and has been followed up to 20 months. In terms of pain results, the pain was improved from 6.9 to 1.9. His gait was able to improve from in a 7 meter walk, and you can see off the drug, meaning levodopa, it can go from 29.3 to 23 seconds. In the United Parkinson's Disease Rating Scale motor examination, there's also improvement without using a drug, just using spinal cord stimulation. It improved from 56.7 to 29, and the examination were all performed with spinal cord stimulation switch on or off for 30 seconds, 30 to 60 minutes. However, tremor did not change in terms when the trying to follow service EMG. There's a Japanese study by Agari and Gait, and basically this there's a 15 patient. Average age is 71 years old. Duration of Parkinson of 17 years. Indication is for low back pain and leg pain. Follow up to 12 months. 7 has a deep brain stimulator. The placement is the thoracic area, and this is tonic stimulation. Again, there's improvement in the pain. In terms of gait, the gait the 2 up and go, the TUG has shown improvement at 3 months, but not so much at 1 year. 10 meter walking, also significant improvement at the 3 months and at 1 year. The UPDRS motor score is significant at 3 months, but not significant at 1 year. But they also report the improvement in relationship between pain level and gait. And again, the motor performance was improved at 3 months, but not at 1 year. This is another study where there's three patients in the study. Average Parkinson duration is 9.3 years, again for back and leg pain. No deep brain stimulator, thoracic placement, and tonic stimulation follow-up 12 months. There's improvement in the pain, but there's no gait assessment. And there's also improvement in the motor examination with borderline significance. And the 1 year follow-up lead to improvement of spinal cord stimulation lead to improvement of chronic pain. Rigidity and tremor has reported to be improved. Mental status is not improved with tonic stimulation. This study is one of the first study using burst stimulation for treatment, and they use a short form to determine the effects of the mental health. They did not perform any gait function. However, they did report a motor examination from the UPDRS from 20 to 6. Overall, they report improvement in low back pain, gait, and stooping posture. Patient also show improvement of low back pain and Parkinson. Mental health reported to be improved based on short form 36 when using the burst DR, and the postulated due to effect of a burst stimulation at the medial effective pain pathway. This study again is basically particularly used for gait dysfunction for advanced PD. This is not for pain in terms of using spinal cord stimulation. So there's no pain assessment. They did show they showed the borderline improvement in gait, in step length, as well as a mean stride velocity. There's UPDRS score has improved, again, somewhat significant in terms of statistic results. They show that the super threshold intensity testing find that is required for gait improvement, and they report step length as well as motor score show improvement, and they also show that the freezing of gait episode has reduced significantly at 6 months post spinal cord stimulation. And there's also reduction of daily levodopa by 115 milligram by 6 months in 3 out of 5 patients. This last study basically is a larger study, the largest study as yet. There's 2 groups, one for tonic and one for burst. The tonic group has 6 patients. The indication is for back pain and vascular pain. None of the tonic group had the deep brain stimulator. This is high cervical placement, follow up at 12 months. The pain has improved, which is significant. Gait also has improved, as was cadence, step length, except stride length is not significant. Overall, tonic stimulation shows significant improvement. In terms of burst group, this indication is only for Parkinson's disease or atypical Parkinsonism. Deep brain stimulator is done in 3 cases, and burst stimulation is used as a rescue. Again, follow up 12 months, and this is high cervical stimulation. The report VAS improved and is significant. Again, gait also had improved in this study. So this slide basically is a summarization of Dr. Mazzone's study in 2019. Again, the spinal cord stimulation indication was used for pain, particularly in the tonic group, whereas motor symptoms for Parkinson's disease was used as indication for burst group. The burst group patient population had 3 deep brain stimulator. Those these patients basically failed deep brain stimulator, and therefore spinal cord stimulation was used for salvage therapy. They found that the longer time is needed prior to showing spinal cord stimulation changes related to motor symptom in tonic stimulation. UPDRS3 were not significantly different in immediate and post-op spinal cord stimulation implant phase, but it was showed different in month 3, 6, and 12 follow-up data. However, in burst group, the motor effects from the spinal cord stimulation seem to be faster and can be seen in post-spinal cord stimulation implant period. There's a slight decrease in pain and motor control observed in 12 months after spinal cord stimulation implants for both burst as well as tonic group. However, burst group has less decrease. At the end of 12-month study, both groups showed there's reduction in L-DOPA dosage. And this particular study was funded by university grant with no industry sponsorship. So in conclusion from the talk, a couple of things. One, the Parkinson disease patient have a high prevalence of chronic pain. Peripheral and the central neuropathic pain are possibly due to PD pathology directly, such as Lewy bodies. Lewy bodies and dopamine deficiency may cause dysfunctional emotion motivational response to pain in PD through medial pain pathway. Additionally, in PD, lateral pain pathway is relatively free of Lewy bodies, but there's decreased activation of lateral pathway, which results in poor pain localization. Tonic and burst spinal cord stimulation modulates all 3 systems that we talk about in terms of chronic pain, specifically descending anti-nociceptive system, lateral pain pathway. However, only burst spinal cord stimulation affects medial pain pathway. Spinal cord stimulation trial in PD patients are thus far very limited to small series and studies. Preliminary outcome has some encouraging findings for spinal cord stimulation helping both pain and motor symptoms in PD. However, larger prospective control study is needed to confirm those findings. Thank you very much for your attention.